everyone. Today I'll be speaking on molecular genetics and clinical characteristics of ocular disorders in children, the mutations, variations, and the complexities involved. I do not have any financial interest in this presentation. As we all know, almost 50% of pediatric blindness is due to a genetic etiology, and eye being only the second organ in frequency of involvement. The central dogma connects the DNA sequence with the phenotype. And the SNPs, that is the single nucleotide polymorphisms, along with larger size sequence changes like deletions, duplications, create all the richness of human genetic diversity at the population level. So the purpose was to analyze the mutations and systemic associations of ocular disorders of childhood and establish a definitive diagnosis on the basis of molecular genetics and clinical characteristics of these patients. The algorithm that we followed was a multidisciplinary approach, and then we went ahead with the whole exome sequencing of these patients after a written consent. The results of the DNA was analyzed, and on identification of any variant, we went ahead with the eye screening on a regular basis of these patients as well as their relatives. So this is a 6-year-old girl who was born to a healthy, non-consanguineous parents, and she suffered from a corneal limbal tear only after a trivial fall. So on repair of this patient, we found out an atrophic scar in the limbal area, and she was suspected with Marfan syndrome, but her general examination did not point towards a Marfan syndrome. So at 1 year follow-up, you can see that the Batten score increased to 5 out of 9. There was skin hyperelasticity and episodes of recurrent respiratory complaints. Echocardiography revealed an aortic root dilatation of 17 millimeter. As you can see from the pedigree, it was consistent with autosomal recessive inheritance, and there was a frame shift deletion at exon 12 of the PLOD1 gene, which actually encodes for lysyl hydroxylase. So an Ehlers-Danlos syndrome of kyphoscoliotic type 1 was detected, and ocular and scleral fragility are although the most notable features of this disease, but they are rarely reported or they are failed to see or overlooked during routine examination. The most life-threatening complication of these children is aortic root dilatation or dissection. The second one is a 12-year-old girl born of consanguineous marriage. She maintained an uncorrected visual acuity of 6/9 but suffered from nyctalopia for the last 4 years. And when on dilated fundus examination, we saw discrete uniform white dots with greatest density in the mid-periphery but spared the macula. They were fewer in number with low autofluorescence signal and absent rod responses on dark adapted ERGs. The sequence of inheritance was an autosomal recessive, and there was a nonsense variant at exon 4 of the RDH5 gene, which actually pointed towards fundus punctatus. This was in contrast with retinitis punctata albicans, which was progressive in nature, but the most important point that we had to see here, or that was concerning, was these patients without macular lesions can sometimes progress to cone dysfunction. This is a case series of 11 children, of which 4 had suffered from upper eyelid coloboma, microphthalmia, and triangular growth of hair extending from scalp to the eyebrow with a symblepharon, and they were of unaffected non-consanguineous parents. The absence of syndactyly or anomalies of urogenital system on ultrasound was absent. So as you can see from the pictures, the only child who had some amount of visual acuity was one of the twins from the pedigree. So you see the pedigree, all the 11 children they had and 4 affected. So this was an autosomal recessive missense mutation of the FREM2 gene, which actually pointed towards the principal syndromic form of Fraser. However, an OMIM entry of isolated cryptophthalmus was identified in the children, and this actually points towards the genetic literacy of health-seeking behavior of the parents in the population. This is an 8-year-old boy born of non-consanguineous parents, and the reason for doing a genetic testing was that the parents wanted to know if the half-sibling of this child actually would suffer from similar features. He had attenuated vessels and RP atrophy on fundus examination, and systemically hepatic steatosis, hypothyroidism, and endocrinal abnormalities, but there was an absence of cardiomyopathy. Pedigree was autosomal recessive, but genetic testing, we did not find any evidence to point towards either side, and it came out to be a rare variant of unknown significance of a rare disorder known as the Elstrom syndrome, which affects the multisystem, and it is actually a ciliopathy. So the problem with these patients is that if we do not monitor them vigilantly, they might go into progressive late onset dilated cardiomyopathy. And definitely these patients, the reason why they came to us was actually for the carrier testing, and we actually wanted to go ahead with the carrier testing for the children. So the genetic heterogeneity and the variant of unknown significance presents a challenge in the clinical context of the disease as well as genetic counseling. So when we are shifting from the genetics paradigm to the genomics paradigm, we need to have a well-developed clinical diagnosis before defining its applicability in diagnostic precision of complex ocular disorders of childhood. I thank by saying that we should be learning from every single family, that we say these are my references and my acknowledgements to my mentors and my co-authors. Thank you. Yes, ma'am.
Talking about genomics for each disease will be quite a costly affair. So how do we go about asking for it?
So, ma'am, if we are talking about omics, genomics means then we are talking about the biomics, that is the biochemistry, that we need to rule out all the metabolic diseases first. So, omics is better than to go ahead with the genetics. That is the genetics. So, if your omics are pointing towards a disease, for example, the Elstrom syndrome, we already knew that he had all the features of Elstrom syndrome. Still, the parents wanted to go ahead with the genetic testing. So, in this situation, it was only to know if the half sibling would have the genetics. So they agreed to do the testing. But we feel that we need a robust system where the finances could be supported by some of the companies, although I do not have any financial interest in this presentation, but we need to have maybe a multicentric studies from all the centers, how the genetics is actually affecting at the population level of the children of various diseases. For example, right now we are looking at Usher syndrome. Several centers are put in to look at the Usher syndrome of retinitis pigmentosa. So maybe that is a beginning.
Yeah, no, because pediatricians they have this metabolic disorders which is going on still.
Yes, yeah.
So that is why I was just asking, because we are new into ophthalmology
Yes,
having it.
yes, ma'am.
Okay.
Definitely. So omics is better. If the omics rule out systemic diseases, then only we can go ahead with the genetics.
Okay.
Thank you so much, ma'am.
I think there is a need for, there are a lot of people in other subspecialties that are going for AI. I think there's a good need for making an app where you can put down, because most of these are syndromes.
Yes.
And you know, when we do our fellowship, that becomes like 20 years back, you remember all the name of the syndromes with their findings.
Yes.
Sort of, you know, it is a culture that when you're doing fellowship, you have nothing else to do, so you mug up a lot of things. At least I used to do it, and I used to enjoy into it.
Yes,
but as the time passes on, you are into practice, you can't remember everything. It is not possible.
Yes.
So it's a good thing. Like nowadays, everything, if you ask somebody, they will Google it and tell you. They will not be actually doing it. Most of us, when we use OMIM, we do online Mendelian also, we do the same thing. We put it. So why not make an app, or if somebody who has resources, make an app for the pediatric ophthalmologist, for the general ophthalmologist, for the pediatricians. At least you come down, you narrow down. As you said, clinically that patient was clear-cut Elstrom. Although you did not show the ERG, did you show?
I did.
Okay.
Target update ERG.
Okay. So if we have that thing, then most of the things are already sorted out. That AI can also tell you what other investigation you need to do, what is the possibility, and also if you're thinking of Elstrom, what are the other things you should be looking for.
I think
there's a burning need for that. That would be a good paper, rather a good useful tool for everybody.
Everyone, because we do not want to miss out on the children. For example, the syndromic Fraser was there, but it came out to be an isolated cryptophthalmus which actually had an OMIM entry.
Yeah.
So these patients that
because
I have
it looks clearly like Fraser.
Yeah,
there is no
that
clinical.
Is what I said.
That's the phenotype.
Yeah, that's what I said, that it pointed directly to the principal syndrome of Fraser. But then it came in the OMIM entry for isolated cryptophthalmus.
But then you never know how these genes will phenotype themselves. Like their manifestation may be slightly different.
Yeah, that is the central dogma of this genetics. And I feel we are beginning, and then hopefully we'll come up with something. Thank you.